Welcome to our first virtual patient and family conference. I know many of you have attended our conferences in the past, and we appreciate you joining us again today. Also, a big hello to all of our first-timers. I want to thank all of our donors, chapters, staff, volunteers, and especially our sponsors, Bluebird Bio, Bristol Myers Squibb, and Chiesi USA for their help and generous funding in support of today's event. While it would be great for all of us to be physically together, I am very excited that so many are joining today online. I know it will be worthwhile. Before we get further in the program, I would like to take a moment and give you a brief update as the National President of the Foundation. To state the obvious, these are difficult and unprecedented times. The Foundation is clearly not immune to the devastating impact the virus has caused. First and foremost, we are focused on the health of all of our patients, which has always been our mission. We continue to be proactive in all the ways the virus may impact our patients directly, both to their health and access to a safe blood supply. I applaud our Executive Director, Craig Butler, for his response to the crisis and his great leadership. Craig has been with the Foundation for over 19 years, and his experience and enthusiasm for his role is a tremendous asset to us all. A very talented staff also joins him as well. You may know some of them already, but a quick shout out and thank you to Eileen, Sophia, Sandy, Kathleen, Mary, and Jonathan. But despite everyone's best efforts, all of our major fundraisers have been postponed. And with fingers crossed, we are hopeful that they will go off as planned in the future. The funds these events raise are vital to our ability to support patients' needs. So I ask everyone to help with our upcoming Care Walk scheduled for September 20th. There will also be a virtual component to the walk. So even if you're not able to join others that day, there is a way for you to be part of the fundraiser. Please reach out to us for more information, and please monitor our social media outlets for information there as well. As your first speaker of the day, I want to give you an overview of how things will work. While most of us are pretty Zoom savvy by now, as a refresher, on your screen is a button to ask questions that will be available during the Q&A sessions after most speakers have presented. We will try to answer every question asked. As this is our first virtual conference, please be patient if we experience any technical difficulties. We are using a platform provided by Doc Events, and their teams assisting us today, so we thank them as well. Again, fingers crossed for a great experience for all. You may have noticed my hair is shorter than it was last year. This is a direct result of one of our patients at last year's conference who linked the length of my hair to their chelation targets. While I don't have much hair left for the next challenge, I am open to other ways to help anyone else that needs some inspiration. One of the best parts of my position is the opportunity to meet many amazing and passionate experts in the field of hemoglobinopathies. One of the brightest stars in this field is Dr. Alexis Thompson, who will be our next speaker. She will speak on COVID-19 medical information for patients with thalassemia, a very timely topic to say the least. You will be in a real treat to hear her present. As a way of background, Dr. Thompson is the section head of hematology at the Ann and Robert H. Lurie Children's Hospital of Chicago. She also holds, and my screen just got a little messed up there, so I'm sorry. She also holds the A. Watson and Sarah A. Armour Chair for Blood Diseases and Cancer at Lurie Children's as well. She is professor of pediatrics at Northwestern University's Feinberg School of Medicine. She has a long and distinguished history as a clinician and investigator on many significant clinical studies and trials, which have elevated her to a leadership position in her field. She was president of the renowned American Society of Hematology in 2018. We have also worked quite closely with Alexis on the NHLB-funded Thalassemia Clinical Research Network, and we have the honor of having her on our own medical advisory board, where her passionate and thought-provoking input has been of immense value. So please join me in welcoming Dr. Alexis Thompson, and I wish everybody a great conference.
Good morning or good afternoon, depending upon where you are and joining us. Peter, I want to thank you for that really kind introduction. It's really my pleasure to be able to join you here from my home in Chicago and to wherever else everyone is. These really are extraordinary times, but this disease and the progress that we hope to make in the disease does not stop. The topic that I was asked to cover today was COVID-19, and it absolutely is on my mind, and I think probably on everyone else's mind. So in the time that I have with you today, what I hope to cover is some background information on COVID-19, the status of the pandemic, both globally and in the United States, COVID-19 issues in thalassemia, and leaving more than enough time, I hope, for questions and answers. I hope that many of this information is known, but I think it's always good to start from the beginning. What do we know about COVID-19? We know that it's a novel coronavirus that was first reported in December of 2019 in Wuhan, China. That the clinical symptoms associated with COVID-19 have evolved. They certainly initially were primarily fever, sore throat, and cough, but we now know that fatigue, nausea, vomiting, muscle aches are also manifestations or presentations of this condition, and that the loss of taste and or smell occurs in many individuals with COVID-19. The incubation period, which is the time from exposure to the time that you might actually see symptoms, can be up to 14 days, but is typically between 3 and 17 days, with an active phase of infection that lasts about 14 days. The virus can spread through the body in tissues that have a specific receptor called ACE2, and that's because that actually is the receptor for the virus that causes COVID-19. And it's seen primarily on tissues like the lung, the GI tract, and the heart, some of the organs that are commonly affected with COVID-19. In general, individuals who have contracted COVID-19 and have had more severe courses or deaths are often those with pre-existing comorbidities, and I'll come back to that. I think it's also important to talk about terminology. When you hear the term novel coronavirus, coronavirus is a generic term. In fact, many of the species or the strains of coronavirus prior to this year are ones that cause the common cold. But having said that, clearly COVID-19 is not the common cold. You may also see the term SARS-CoV-2. This refers to the actual virus that causes COVID-19. And then where do we come up with COVID-19? COVID-19, the CO stands for corona, VI, virus, disease, and 19 being the year in which it was discovered. This is the disease, COVID-19, that is caused by an infection with SARS-CoV-2. The global impact is clear. It's interesting. I put these slides together earlier this week. And earlier this week, this is a map from the Johns Hopkins Project. There were nearly 2 million cases worldwide. There are now over 12 million cases worldwide. And the U.S. has the largest number of cases in the world right now. There were over 3.2 million cases as of this morning in the United States, followed by Brazil, India, and Russia. And when I put these slides together, there were over 131 million deaths. As of today, there are over 135 million Americans who have died from COVID-19. When we look at the day-to-day increase, I think it's fairly clear that for some of you on the East Coast, you may have seen more of this in that early phase, but that the number of cases that we're seeing in the United States over the last 2 months is rising. When I finished off these slides just a few days ago, we had just barely peaked at just over 50 million cases per day. And as of today, we are almost 70,000 new cases each day in the United States. So clearly this outbreak is far from over in our country. This actually is a map from the Harvard Global Health assessment, and it looks at where it is rising. And so this is looking at the number of new cases per 100,000 population, with red being the areas where there are the largest number of new cases. And for anyone who's been following in the media, the concerns that are being raised in southern Florida, in Arizona, and in Texas are reflected by the increased number of counties that are red in those states. But clearly there's no part of the country at this point that is unaffected by COVID-19. COVID-19 and thalassemia, I think is really the focus that I want to cover today. And really, I want to look at what we know and what we don't know. I want to thank some of my colleagues, Nika Capolini and Antonio Piga from Italy, as well as Janet Kwiatkowski from the United States, who we were asked as a group by the American Society of Hematology to answer a series of questions that were being raised by other hematologists about what we should be concerned about in thalassemia. And so what I'm providing for you is what some of our collective thoughts were. I hope that they'll answer some of the questions that are highest on your mind, but certainly we'll have time to add to that. So let's get started with questions. First and foremost, are patients with thalassemia more susceptible to serious COVID-19 disease? Now, what I will say from the outset is that this is I will provide for you the information that we have. There is not a worldwide registry for patients to collect this in real time. And so the groups that have given us the most information about this are from Northern Italy, Iran, and the UK. And so based on the information from these registry efforts, what we can say is that what we already know, and that thalassemia is a chronic health condition associated with comorbidities or complications involving some of the same organs that we know are highly at risk in COVID-19. But that the outcomes from a study in Northern Italy has showed that most patients are developing mild to moderate symptoms of COVID-19. This is also what's been seen in Iran and also what's been seen in the United Kingdom. The number of infected patients, quite frankly, has been lower than we might have expected. We think that this is because thalassemia patients in general have been more vigilant in terms of self-isolation compared to the general population. But certainly we continue to be very much on guard, and we think that it's so important for us to be sure that we're continuing to monitor this situation. Does splenectomy confer a higher risk? Now, I think as many of you already know, that in many instances, splenectomy is in general an effective treatment for some individuals with thalassemia, although I have to say that I'm doing it far less often, in particular with my younger patients. But certainly many of my older patients with thalassemia have already had their spleens removed, and that it has been a quite effective way to reduce their need for transfusions. Splenectomy is not known to increase the risk of infection or the severity of viral disease, but that there's no specific data on splenectomy and SARS. What we can say is that the majority of the patients in Northern Italy who developed COVID-19 had been splenectomized, and their cases were not more severe, and that a subset of the patients that have been identified elsewhere have also had splenectomies, but it did not seem to increase their risk. Splenectomized patients who develop fevers, however, should be evaluated for possible bacterial infections. They should receive antibiotics to cover for secondary bacterial infections. And I'd be remiss if I did not remind people, whether they have their spleens intact or not, that if you have a fever, not only should you contact your health provider, but you should actually discontinue your iron chelating agents. Should there be any changes in your transfusion schedule or transfusion thresholds in the context of this pandemic? I think that's a really important question for all of us to consider. At present, there's no evidence that SARS-CoV-2 can be transmitted through donated blood. And so for those who are committed donors, please continue to give. And for those who require blood, you should not be concerned that the blood that you might receive could potentially be contaminated. There is no evidence whatsoever that that is the case. In our opinion right now, it's advisable to maintain an individual's chronic transfusion regimen without alterations. It's not to say that we don't recognize that there may be some shortages to be considered, but for now, clinics and infusion centers should offer transfusions the safest possible environment for receiving transfusions. What that's meant for most of us is being sure that when our facilities need to take care of people who are suspected or who are known to have COVID-19, that they are cared for safely in areas that are separate from the infusion centers and the spaces where our patients need to be transfused. And so you should feel confident entering a healthcare facility to get your transfusions, that we are doing everything that we can to keep you safe. What about blood shortages? Early in the pandemic in the United States, it was wonderful to see the number of people who were stepping up to actually undergo or to donate for blood. We are hearing reports, however, about some regional and local shortages, in particular in the South. Hematologists and other thalassemia care providers should continue to look for local and national developments related to possible blood shortages, blood shortages related to COVID-19. Clinical sites and blood banks may need to develop contingency plans for adjusting transfusion regimens and obtaining the appropriate units for individuals who are alloimmunized, because those individuals often need to have specialized testing done to find the best units for them. And so whenever the blood supply is affected, those people are at particularly high risk. But again, this is a very individualized situation, but we encourage people to begin thinking about what they might do in the event of shortages. Should thalassemia patients continue iron chelation if they're exposed to or have confirmed COVID-19? It's a great question. There's no data available regarding iron chelation and susceptibility for COVID-19, so we do not believe any of the iron chelators make anyone more prone to developing COVID-19 or having a more severe infection. If someone with thalassemia is exposed but has no symptoms of COVID-19, there is no reason to interrupt your iron chelation. If a thalassemia patient develops COVID-19, particularly if they have moderate or severe symptoms, then interrupting your chelator is advisable. But you should continue to have ongoing communication with your treating physician and your thalassemia specialist. It may very well be that there are increasing numbers of people who actually are being monitored from home. So people with mild to moderate COVID-19 are not always being hospitalized. But please, it's so important to make sure that you have a way to have ongoing communication with your treating physician so that if things change, we can actually move to the next step for you promptly. What about treatment with the recently approved drug luspatercept during this COVID-19 pandemic? Again, another important question. There's no data available to date on luspatercept and COVID-19. Again, we do not know that luspatercept makes you more susceptible to getting COVID-19, nor that it's any more severe. If patients are currently taking luspatercept, there are no theoretical reasons to stop treatment. If treatment with luspatercept has just decreased your transfusions, then continuing treatment should be beneficial in that you should have shorter clinic visits, and it may decrease the number of units of blood you get, which may be really important in decreasing utilization of what may become a limited blood supply. So if you're on luspatercept, you're doing well. We see absolutely no reason why you should interrupt that. This drug is now FDA approved for adults, and so that if you and your hematologist are considering starting it, I think you should continue to have that conversation. Certainly the patients of mine that are on it have already reported benefit, and I'm looking forward to Dr. Sheth's talk later on in our conference, who I trust will cover luspatercept as well as other things during his presentation about new therapies. What are the recommendations for stem cell transplantation or gene therapy for thalassemia during the COVID pandemic? My institution's been involved in both efforts, and certainly earlier this spring, we elected to discontinue all transplants that were not emergent. And so any transplants that were being performed for non-malignant conditions were put on hold. We've moved back to actually performing transplants and gene therapy in our institution. Most transplants were postponed during this initial phase, and many institutions, however, are going back online. In areas with falling COVID-19 rates, patients and their physicians can begin moving forward with planning the procedures, particularly in patients with gene therapy who have already had their stem cells harvested, or patients where we know there might be some limitations in the donor for those who are undergoing allogeneic transplants, that we think that we may now be in a situation in many parts of the country to proceed. There's no evidence, just like with blood, there's no evidence that SARS-CoV-2 can be transmitted through stem cell grafts. And so we feel confident that this should not be a reason for postponing these therapies. But again, worth having a conversation with your thalassemia specialist as well as your potential transplant program. So some final thoughts. I would strongly encourage our thalassemia community to be as vigilant as possible in staying safe and healthy. Adherence to iron chelation and your schedule that's been recommended by your thalassemia care provider will reduce organ injury and thalassemia complications, because remember, those who are having the greatest difficulty with COVID-19, whether it's from thalassemia or otherwise, are people who have organ injuries, sometimes from aging, sometimes from other chronic diseases. And so iron chelation, keeping your transfusions on schedule are going to keep you healthier. Keep all your scheduled appointments with your hematologist and other specialists, whether that's a telemedicine visit or an in-person visit. We strongly encourage you to continue to keep your appointments. We anticipate the recommendations for thalassemia and COVID-19 may change, and so having flexibility and being aware and keeping in constant communication is the only way that you'll have the most up-to-date information. They've changed certainly for me and my team and my families over the last 3 months, and I dare say that there may be changes to come. Finally, it's also important to find reliable sources of information. And so I've included on this slide some resources that I believe that all families should take advantage of, including those from the Anemia Foundation, the Thalassemia International Federation, and the Centers for Disease Control and Prevention. All of these are scientifically sound places to get information about COVID-19. Also talking with your provider to ask questions about whether or not facts that you are obtaining from these sites specifically apply to the specific needs of you and or your child. But please make sure to use evidence-based sources for your information and to talk to your provider before making any changes. And finally, I'd like to thank all of you who are willing to continue to wear your masks. Thank you.
Thank you, Dr. Thompson. Excellent presentation, answered a lot of questions. We do have a few questions that have come in, and I encourage anyone that has other questions to go ahead and type them in to the question area, and we'll get to as many as we can. But I'll start off with one. We know there's been so much conflicting information that's come out because everything is developing, and sometimes things get put out there and we don't, we hear them and then it goes away and we don't know what's going on. And at one point there was some discussion that there might have been, I guess, more of an affinity for COVID to work on people with certain blood types. And I just wonder if that's anything that has been explored, if there's any kind of answer in that area, or if that's something that's still just up in the air.
So thanks for whoever sort of submitted that question. I think that is something that is out there. There's some evidence to support that, but it's in evolution. There certainly seem to be certain blood types that have been seen more frequently in individuals who have more severe COVID-19. Our blood type obviously is something that we're born with that cannot be changed. It's not clear to me that alone is the primary reason for anyone to have severe COVID-19, nor that it necessarily makes them at higher risk. I think that this is something, though, that needs to be continued. We need to continue to see where the evidence takes us. I don't believe that I would change anything for any individual based on their blood type, but this is certainly one of many factors that are being explored.
Thank you. And this actually is a question I'm going to put out. Somewhere along the way in the earlier days of the pandemic, the foundation was getting calls from some of our patients, not a lot, I'm happy to say, who are being told that their blood bank was not going to allow them to be transfused unless they got down to a certain lower hemoglobin level. And that raised the issue of who is it that actually makes the determination? Is it the blood bank or is it the doctor that is making that decision?
The final decision is, more often than not, is actually the treating physician. I think that certainly there were initial concerns about the safety and the adequacy of our blood supply. I think the issues about the safety of our blood supply were answered very quickly, that there is no greater concern or risk of getting transfused now than there were before the beginning of this pandemic. I think that certainly the concerns about, will we have enough blood for everyone who needs it, is also a fair concern. That was mitigated in many areas because elective surgeries were postponed. And certainly that allowed individuals like those with thalassemia who truly need blood as life-saving to have access to the blood in blood banks. I believe that that is still the case. I think that many of our thalassemia patients are as healthy and as vital and as vigorous as they are because they get transfused on a regular schedule with the amount of blood that they actually need. There are many institutions that for other patients with other conditions that there have been threshold values that have been put in place, in fact, that are evidence-based. That is not the case for thalassemia. And so it often simply requires a conversation between the thalassemia treater or the physician ordering blood and the blood bank to really reinforce that thalassemia patients are different, and that we have evidence that our patients will remain healthier if they are consistently given the amount of blood that they actually really need. And so to that end, we strongly discourage there being disruptions in their care. I think that if a provider finds that they need additional information, please know that those of us who are part of the medical advisory board for the Cool's Anemia Foundation are more than happy to have one-on-one conversations with providers in our areas to give them the most up-to-date information about thalassemia, about the need for transfusions, and about why it is so important to not reduce the amounts of blood that are being provided for patients.
Thank you. Our next question starts off by saying the CDC classifies sickle cell as being high risk for COVID and thalassemia as might be at increased risk. And the person asking the question says a clarification of what this means would help parents in making informed decisions, especially relating to the school year, and help in communicating the same to school administrators. So I guess the question would be, what is the difference between being at high risk and might be at increased risk, and what information can be drawn from that can be helpful in making determinations about returning to school or about communicating to school administrators about thalassemia?
So thanks for that question. Certainly sickle cell and thalassemia are diseases that are commonly talked about in the same sentence. And it of course stems from the fact that both of these conditions, while they are very different, they arise from a mutation in the same gene. But the manifestations of sickle cell are far different. And thus far, the susceptibility to COVID-19 and the outcomes to COVID-19 have been different. So for instance, there actually is a registry in the United States that is collecting information on sickle cell disease. And so there actually is reason to be more concerned about those individuals, because compared to the general population, their courses do seem to be somewhat higher risk. And so that certainly in many ways is part of the reason for the CDC making that comment about sickle cell, because we actually have COVID data that suggests that in fact we should be, there should be a level of concern that's somewhat higher for sickle cell than the general population. I think that anything we can do to mitigate risk for the general population is bound to benefit individuals with thalassemia. But I don't think on an individual basis we can use that to necessarily make decisions about some things that are involved with the individual. So that just to say that sickle cell has some of the same organs that are affected in thalassemia, but they also are some of the organs that seem to be most at risk for being attacked by this virus. And so that in part explains the difference between the two. But I wouldn't make a lot of that one versus the other in terms of making decisions about school.
Thank you. Our next question is simply, do you believe it is safe for thalassemia patients to be out in public like nothing is wrong?
Well, I don't believe it's, these are different times, and I don't know how many times we can say that. I don't believe that anyone can be in public as if there is nothing wrong, and I can't emphasize that enough. I think some of the basic precautions that have been recommended repeatedly on social distancing and wearing masks are real and absolutely should apply to thalassemia patients. They certainly are things that I do myself as a thalassemia treater, and I can't emphasize enough how important it is for all of us to be responsible and to actually use these very simple measures that are recommended by almost every credible scientific source, that social distancing and wearing masks are saving lives today. Having said that, I think that we, when possible, people with thalassemia need to be able to attend their clinic visits, need to be able to come in to get transfusions, and need not be afraid of doing those things. But I think that it is senseless to put one's health at risk, and more importantly, the risk of your loved ones, by not doing simple things like social distancing and wearing masks.
Thank you. Our next question is from someone who does not live near one of the major thalassemia treatment centers, and so has to fly to get to a center for their annual comprehensive care checkups. They're fearful about getting on an airplane, and they're asking about options for that. So I guess one way of looking at this would be, do you recommend delaying comprehensive care checkups at this point if you're going to have to get on a plane, or do you think there are other options that they can explore, perhaps involving telemedicine options, which might be useful at this point?
That's a fantastic question, and it's not an easy one. I would recommend that this individual speak to the center at which they receive their comprehensive surveillance visits. Many of us, in fact, most of us, have now moved to telemedicine for some of our care, but not all of our care. And so one of it is exploring what are the options for telemedicine. I know that MRIs with iron quantitation are still not universally available, and that in many instances the most accurate assessment for your risk of iron overload really is being performed at these specialty centers. Again, I would talk to your usual comprehensive center to find out what is your status. For someone whose iron chelation status has been stable, who has a moderate to low iron burden, postponing makes sense. For someone who is on dual chelator or is having other complications from thalassemia that are being monitored very closely by specialists, they need to talk to that team and to make it a very individualized treatment. As best I can tell, again, this is sort of as reading the same lay sources as most on this call, air travel requires some preparation and requires some thought. It would seem that there are a number of efforts being made to make air travel as safe as possible. But I think first and foremost, I would make a call to that center and to see what are they seeing in their area, how severe is the outbreak, and what can we do to make this the safest decision for that patient.
Thank you. Our next question is regarding parents of children with thalassemia. What are the recommendations for these children returning to school if schools are reopened? That's
an excellent question, and really I think such an important one right now. when I made that statement about that things are subject to change, I think school is probably the biggest one. And frankly, it may very well be that a recommendation that I make in July may not apply 6 weeks from now. And I think that that's very important. At the moment, we are seeing continued rise in the number of new cases daily in the United States, but it's quite regional in terms of where the biggest spikes are being seen. Decisions about schools are local, are usually either state or local school boards. And I do believe that states and school boards are working very hard to use the best scientific evidence to determine what is the safest environment for children. It's balancing that against the absolute needs. As a pediatrician, I'd be remiss. I fully support the AAP's perspective that children need to be in a classroom, that there are great benefits for children to continue their educations. It may very well be, however, that in certain areas, the classroom itself needs to be virtual, and that a physical classroom may not be the safest space. I think it needs to be on a case-by-case basis. And so as we get closer to the beginning of the school term, wherever individuals with thalassemia are, they should talk to their thalassemia treatment center and to look at what the recommendations are for your school district. Thalassemia patients can attend school safely. But I do think that it needs to be in the context of what the recommendations are otherwise in your school system. I think it's safe to say that most educators are trying their hardest to determine what is the safest way to educate our children. I honestly believe that. I do not believe that they want to expose teachers, school staff, or children to unnecessary risk, including children with thalassemia. But I don't have a crystal ball, and I certainly can't envision what that's going to be for every individual on this call. But I hope that in talking with your thalassemia treatment center, you can be confident that whatever decision that you're making is the one that's based on the best possible science at this time.
Thank you. I have a comment here from George Constantinou, one of our friends from the UK. Hi, George, who writes just a comment: as a percentage of the population of sickle and thalassemia in the UK who have been affected with COVID-19 is actually the same. So thank you, George.
I also want to thank my colleagues in the UK for the great work that they're doing, because they have a hemoglobinopathies registry. And so the data that they presented at the European Hematology Association meeting less than a month ago was really the largest number of thalassemia patients to date. And so I thank them for the work that they're doing. So their ongoing data collection is remarkably helpful to all of us.
Excellent. We have a question here which asks, should the ferritin levels be done during the COVID-19 pandemic, or is it better to delay them?
I would do them. There's no downside to that kind of data. The serum ferritin should not be, the absolute number of your ferritin should not change just because we're in the middle of a pandemic. COVID-19 is, because it's an infection, infections in general can make a single serum ferritin value elevated. But in the setting of someone who actually does not have an active infection, does not have COVID-19, their serum ferritin can still be a very valuable tool to assess iron overload. And so I would not forego checking. To the contrary, I would continue on with as much of your usual care as possible.
Excellent, thank you. I think in particular because we're seeing, unfortunately, huge increases in the U.S. again, which could lead to even more people being isolated again, and therefore more potential problems with donations to the blood supply. One person asked, do you have any recommendations for a plan B that we should try to put in place now in terms of stemming any upcoming blood shortage issues?
I think there are a couple of things. first and foremost, encouraging your family and friends, anyone who's healthy enough to donate blood, to please do so. Again, the American Red Cross and other centers that are procuring or collecting blood products have all participate with social distancing and wearing masks, and their regimens are very clear in preventing individuals coming in to give blood from getting COVID-19 in the process. And again, there is no evidence that COVID-19 can be transmitted through blood. So first and foremost, encouraging your friends and family to donate blood. The second is having an early conversation with your blood bank, making sure that you understand, I as a treater understand their perspective and that they understand mine. That when they're looking for opportunities or patient populations to consider making adjustments in, that they understand how critical it is for thalassemia patients to continue to receive the amount of blood that's currently prescribed. Now, having said that, I think many of us, when we're thinking about the calculations for transfusions, in children, it is often based on weight, so cc's or mLs per kilogram, and adults more often in units. I think it's safe to say that if I'm transfusing a child and most of their transfusion need can be accomplished with a single unit, and they only need a fraction of another unit, that's a conversation worth having with your blood bank. It may very well be that if someone only needs 60 mLs, which is no more than a couple of tablespoons of blood from the next unit, that perhaps foregoing that unit, leaving that unit on the shelf for another individual, perhaps asking that thalassemia patient to come back half a week or a week earlier for their next transfusion, is going to actually allow a unit to be made available for another child. So that's a very individualized way to do without compromising on the health of the individual with thalassemia. I don't think that we're prepared to say that thalassemia patients should go back to the days where they receive minimal transfusions. We know that your organs will not stay as healthy with that kind of regimen over an extended period of time. And so if at all possible, between trying to do everything we can to encourage donations and to being thoughtful about orders for individual patients and the number of units that are prescribed for them, I think we should be able to find our way through this this pandemic. But I encourage providers to actually to think this through early, to talk to other thalassemia specialists if you need to, and certainly to consult with your blood bank.
Thank you. Our next question is, do you feel that thalassemia patients are immunocompromised?
I think it's one of those questions, it depends. When I look at thalassemia patients who have not been splenectomized and who do not have severe iron overload, I do not believe they're immunocompromised. Iron overload does compromise your immune system, and those who no longer have intact spleens, who have had splenectomies, are at higher risk for bacterial infections. And so it's that aspect of immunity that I think is compromised. Again, we don't think that individuals who have had splenectomies are at high risk for viral infections. And so the thing that I worry about most with in this particular pandemic is obviously, whether or not the COVID-19 will make them more susceptible. But I think that, again, doing all the things that we can do to keep ourselves healthy as a thalassemia community, with continuing to be very vigilant about using your iron chelator. And in many instances, we already are doing splenectomies far less often. We really should be seeing fewer and fewer people with thalassemia who really have any immunocompromise at all.
Thank you. I'm going to combine two questions here, which I think are somewhat related. Is there any data that indicates that there is more susceptibility or severity for people in terms of COVID-19 with different types of thalassemia trait? And also the same question in terms of whether someone has non-transfusion dependent or transfusion dependent thalassemia. Is there any data that suggests a difference in severity or susceptibility?
So the question about susceptibility or severity of the disease with thalassemia trait, the answer appears to be no. And the reports that have come out of northern Italy, the UK, and Iran, they included patients with non-transfusion dependent thalassemia, as well as those with thalassemia major, and there were not differences. Most people had mild to moderate disease, and so we don't think that that they're at higher risk than the general population. But certainly anyone in the current setting, especially those who think that they've had an exposure to someone who has COVID-19 and who develops symptoms of COVID-19, they should certainly at the very least contact their health provider. I would suggest against immediately going in and seeking care. Emergency rooms are prepared to a certain extent to evaluate individuals, but there are many people who have mild COVID-19 who are not being seen in doctors' offices and who don't need to go to the emergency room. But based on the studies that have been done so far, we don't think that thalassemia trait or NTDT are high risk factors.
Thank you. I had a follow-up question in terms of parents concerned about sending children back to school. This is actually from someone who is an adult person, an adult individual with thalassemia with several related comorbidities, who works as a teacher in an elementary school and is asking your advice on, is it safe for her to go back to teaching?
There are many school districts that are absolutely as concerned about their teachers and their school staff as they are about children. And frankly, there are many people who are teachers, not necessarily with thalassemia, but certainly with comorbidities or they are in other high risk groups, because we know certainly people over the age of 60 are at higher risk. I do think that there are conversations that are ongoing about how to keep everyone safe. There are many school districts that certainly are very mindful. I think no one wants to lose experienced teachers in any school district. And I think that they are, I think teachers, I think that many of my friends and colleagues who have been teaching their children at home have a new appreciation for the role that teachers play. And so I think that there is quite a bit of interest in making sure that we're protecting teachers. I would encourage that individual to continue to work with their school district. I believe that they will not be alone in being among those teachers that we need to actually think through how are we going to actually allow them to do what they do so well, to provide the education for our children that they want to do and that our children so much need, but to do it safely. But I do believe that many school districts are taking that very much in consideration, because we do not want to lose some of our most experienced teachers.
Excellent. So I think we've just got time for one more question. I'm going to combine these two because they both are follow-ups to the question about compromised immune systems. One of them is, are there any immune boosters for people with thalassemia during the pandemic? And the other is in reference to iron overload causing a compromised immune system. Is there data on what level or measurement of iron load tends to lead to a compromised immune system?
So the question about what can you do to actually make yourself healthier? And I think one of the best immune boosters really are things like exercise and enough sleep. And so without necessarily, and that can be done. I know that I've taken more long walks and my dog's really happy about that. And I think many of us are not able to get sleep as much as we could during this pandemic, yet we know that those are things that are very important for our overall health, including our immune status. Antioxidants have been associated, and antioxidants include things that are in multivitamins, but things like vitamin E are certainly, and vitamin C certainly are known to be things that have some benefit in terms of our immune status. I don't recommend mega dose therapies of any kind, but I do think that having a multivitamin and to be mindful of getting enough vitamin D and vitamin C is always important for people with thalassemia. The second part of the question, Craig, was related to?
Is there a certain level of iron overload that tends to be more associated with the compromised immune system?
It's not the absolute level. Usually it is the length of time at which someone is above a target range. And so this is the reason for being vigilant over a long period of time. If patients with thalassemia don't get iron overload overnight, and certainly you can't get rid of it overnight, but it is certainly far better to avoid it altogether. There's not an absolute number. But certainly those who have good control of their liver irons based on MRI or SQUID, it's safe to say are those who have less immune compromised, and those who have much higher liver iron contents are those that I worry the most about. There's not an absolute threshold, but I would say if there are individuals who have been told that their iron needs to come down, this is yet another reason to take control of your life, to look at how you can optimize your iron chelation to get your numbers in an optimal range, and to work with your thalassemia treatment specialist on what that range is and which drugs you need to be on. Some people need to be on more than one drug at the same time to get there, but to have that kind of conversation. So if you're looking for yet another reason to get your iron under control, let this COVID-19 be that new reason.